not appropriate. So who speak up for the patient? No one, right? So when I come in, I will look at patient's medication. I will recommend physician to reduce the dose if appropriate, or get the patient off medication. So, so I want to share with you, this is one of my favorite topics because I deal with this every single day when I review charts. Always have psychotropic alarms all the time, every day. I look at the patient where's my psychotropic medication? What can I do about it? Can I help reduce it? And I see a lot of duplication of therapy. That's the issue. So if you go to your primary care, you have one med. You go to your psychiatrist, you have the med. So nobody talk. Sometimes I feel I have seen two providers give two different meds with the same class, and that's a duplication of therapy. And you know, when you have duplication of therapy, that means you have more side effects. It might help you at that moment, but then what's the consequences after? So I want to share with you what I learned. This is what I learned, and then what I see in real life, and then what I can do to help you. Or you can help, you go back home and you help your family members, like your friends in nursing home or even in the community. So let's start with the definition of psychotropic medication. So any medication that affects the brain will count as psychotropic medication. So usually we just think about antipsychotics, antidepressant, anti-anxiety, or hypnotic medication. But now Medicare put in another small line, other medication. So some physicians will use anti-seizure medications as antipsychotic. So it's a sneak in, because before it doesn't count against the facility. But now if you sneak in an anti-seizure to treat psychotic issues, then it counts. So they're watching closely for facilities, nursing home facilities that use anti-seizure medications to control the patient or the resident. So, or if you take supplement, melatonin is supplement, right? Guess what? It counts because you treat it for sleep. So if you calm your brain down, it counts as psychotropic medication. So slowly, so slowly, Medicare tried to nitpick on what do you use to control the resident's behavior. So some facility use melatonin to control the behavior of the resident during the day. So they take it twice a day instead of once a day. They take it twice a day just to control behavior. Or they use methoxyprogesterone, progesterone medication to control sexual behavior in male resident. So does it count? It's a behavior issue, but it's a progesterone medication. So it's not antipsychotics, none of that, but you use it to treat the condition, a behavior condition, then it counts as psychotropic medication. So it's very, for a long time, like nursing home, like try to use other medication instead of antipsychotics to control behavior of the resident. And now Medicare will come in and say, hey, pharmacist, did you recommend doctor to review those medications, even though they're not antipsychotics? So I have to get into the chart and say, okay, why do you take this medication? How long? And then is that time to get them off? Because sometimes they only have that behavior for just that day, right? If you have just one time and you're on it for a long time and they just keep renewing medication, month after month, and nobody really say why. Or even the family member come in and don't even, like, why my mom's still on that medication? Did you ever ask? that question, like why my mom's still taking that depression medication. She's not depressed. She's happy all the time. So I have patients come to see me privately about antidepressant. A lot of people on antidepressant because they lost a spouse for like 10 years ago. And they're still renewing antidepressant. When I ask them, why are you on antidepressant? Are you depressed? I'm like, no, I'm happy. Then get off that medication. So if you're not depressed, don't take depression medication, okay? If you don't feel you crazy all the time, it's just one time that you have a burst of anger, just that one time, and now you're fine for the rest of your life, then get off that antipsychotics. Does that make sense? And then you, in the community, you can speak up. You can talk to a physician about it. Imagine resident in nursing home. They have nobody to talk to them. I haven't seen physicians spend time with the patient at all. When they come in, what I heard is, they look at the chart. They don't look at the patient. Exactly. That's a big difference. If you look at the patient, you see, you will make different decisions than just looking at the chart and how other nurses report it to the patient, to the physician. And the physician only come in to see like once a month or every 2 months. So, like for me, I only look at the chart. If it's a nursing homes, a skilled nursing home, I look at the chart once a month. If a assisted living, every 3 months. So I can only catch the mistake 3 months later. So when I catch duplication of therapy, I catch wrong dosage, I catch all kinds of mistakes 3 months later. Imagine if nobody look at that. Even physician look at it I would say, okay, physician, you look at the order, you sign off the order every month. Why don't you catch the duplication of therapy? Why this patient on 3 antipsychotics? Why? So that's the issue that happened in long-term care. And I don't want it to happen to you. And I think that's why you're here. You want to learn more how to prevent this polypharmacy issue. So what questions do you have for me so far?
You mentioned melatonin. Usually that's taken to help you sleep, is it not?
Yes.
What alternative is there?
For sleeping alternative means you want supplements or you want non-pharmaceutical?
Probably non-pharmaceutical.
I would talk at the end.
Okay.
That's a good question. Yes.
I was prescribed Celexa years ago. I don't know how many years ago now.
Okay.
And they said I had dysthymia, just lower than everybody else all the time. And I wonder if I should stop taking it. My family doesn't want me to.
See, now this is the issues. So same thing with patient nursing home, right? If I recommend to get a patient up, and the answer will be like family don't like that. So family want to control you, right? So it is you who feel like you need it or not. So you have to look into you and say, what if I don't take this medication? What if I wean myself off? Well, of course, you're going to discuss with your doctor, because do not get off any medication that affect your brain abruptly. So you have to wean yourself off, like taking half of the dose or like every other day. And you have to wean off at least a month to get that off. You don't want to rebound. Does that make sense? So if you think that you don't need that medication, try to wean yourself off under the physician direction and see, does that make a difference or not? At the same time, you can supplement yourself with vitamins that help your brain. So you don't just wean yourself off one chemical, you have to replace it with vitamins and supplements that help to make your brain healthier. So once you have your brain healthier, a lot of mental issue will go away. So I have seen people, like in nursing, I'll give you an example. for people taking Lasix, a lot of elderly taking Lasix for heart failure, right? So one thing with Lasix is make you dehydrated. Once you dehydrate, guess what? You go crazy. Guess what next? You on antipsychotics because of dehydration. All they need to do is to lower Lasix dose. That's it. So you don't get too dehydrated. So your brain needs water, need vitamins, supplements, and water. So if you dehydrate it, then you will, you know, or infection. Sometimes elderly get infection in nursing home, and you know they just cried out, right? Guess what? They're on lorazepam, Ativan. So when before you get on a medications, ask yourself, is that a side effect of a condition or side effects of other medication before you get on to another medication?
So what are some of the supplements
Supplement
for the brain?
So supplement for the brains will be the vitamin D, especially B12. So B12, folate, iron. Make sure you check iron, so you don't want to be anemic. So that's the popular. So when you go out to a pharmacy, you spend $50 for a brain supplement. Look in the back. Say what it is. Vitamin B6, B12, folate acid. So that's what you pay $50 for. Okay. So you can do the same thing, and then make sure you eat a balanced meal.
You said vitamin D, B12, vitamin B6, and folic acid?
That's what's in B12, right?
B12, B6,
Oh.
folate acid. Those are for the brain, right?
Oh.
That specifically for the brain. And magnesium. Make sure magnesium is very important for sleep. So if you have sleeping issue, you take melatonin, it doesn't help, or other sleep medication, magnesium, you have to check your magnesium level.
And it should be at night.
At night. You take magnesium at night, it's very helpful with your sleep. And also with other conditions.
I've had some clients recently get infusions, iron infusions, and I just see such a difference in them.
Yep,
when
the
they get
iron, yeah.
infusion.
So make sure you check your iron level, B12 level every year, okay? Every year when you go to annual checkup, always check your blood. But you have to request it. Sometimes physician won't order it until somebody requests it because you have to pay extra. I mean, the insurance have to pay for it. So check, and vitamin D also. Vitamin D is very important for your bones, right? So vitamin D help with depression. A lot of research say vitamin D help with depression, also help with your immune system, okay? Okay, let's move on to the next page. Okay, so
No, for vitamin D.
No, she didn't say B.
okay, so the next one.
She
I
did it
know.
for your bones.
Yeah, but you take it for your brain too.
So antipsychotic black box warning. I bet none of the doctors read this. When they prescribe an antipsychotic for dementia patient, they don't look at black box. You know, when a medication have a black box, that means there's death or something really serious taken. When a patient on a medication and they have a black box, the doctor have to think it twice or have to monitor the patient.
There's a black box on the bottle.
Black box. So when you buy a prescription, there's a leaflet, go with it, open it, there's a, read it. This is like small letters, but read the black box. So today we talk about antipsychotic black box. So if you, so in elderly patient with dementia, you know what, when people have dementia, they can go crazy, right? But it's not them that go crazy. It's just their behavior. They cannot express themselves. They can yell at you because they can express themselves. I'll give you a story. I work in a memory care unit I think down the street on Glade Avenue. They have a memory care unit. So I was in the memory care and a patient come up and said, hey, can you call my mom for me? And it's in the memory care. So I said, well, I'm sorry, I don't know your mom's phone number. She's like 80, 90 years old. And then I keep working and she keep like, can you call my mom for me? I said, I don't know your mom's phone number. And I feel bad. You know, I understand. So if you are a nurse working every day, that would be annoying, right? Like, okay, I'm gonna sedate her, tell her to go away, right? But guess what? A CNA come up and dial up the phone number in front of me. She used a phone on the table, and I thought it's a fake phone number. No, it's her cell phone. So she called her cell phone and give that phone to that lady and talking to that lady as her mom.
Wow.
I was so impressed. And after she talked, and the CNA talked to her and said, I love you, okay, you know, you go back and blah, blah, blah. It's very sweet. It's a sweet talk. I was listening to that. I was in awe. This is how you're going to treat the patient. You go with the flow. You play with them. And then after she hang up, and that lady come back to me again saying, hey, I just talked to my mom. My mom loves me. And then she quietly walk away. That's it. You don't need any medication. You just go with the flow. You play the game with dementia patient. You don't need any medication for that. You just go with the flow. I learned this in class, like go with the flow, but I don't know how to react in that situation. And that CNA taught me this is how you're gonna react to the patient who want to talk to the mom. Give them the phone and talk to them. This is amazing. I feel like, see, this is how we should treat dementia patient, not put them on antipsychotic.
Amen.
Does that make sense? Okay. So because there's a reason. A lot of time when you put dementia patient on antipsychotic, they're gonna die. It's just the way it is. The brain already, you know, not functioning very well, and then you put more medication that sedate the brain, they're not gonna, you know, live a good life. So this is the reason behind why we have to reduce antipsychotic use in elderly patients. And if in case you know someone on antipsychotic, you may have to reevaluate that use. Okay, if sometimes you use antipsychotic for anxiety, that's the wrong indication. I see that in nursing home. They use antipsychotics for sleep, antipsychotic for anxiety, for depression. Why don't we use antidepressant for depression, not antipsychotic for depression? So that's why there's a duplication of therapy. People on 3 antipsychotics for anxiety and depression, or for sleep. And that's the wrong use of the medication. Does that make sense? Absolutely. And now you know there's a black box warning for using so many antipsychotics. And now I received a letter from insurance to ask me to reduce the use of antipsychotics for a certain patient now. So I got the fax last week saying, hey, pharmacist, can you look at this patient on 2 antipsychotics? Can you reduce it? So I have to, so when I receive that fax from insurance, I have to make a recommendation to the physician, like, look, you have to get rid of one of the antipsychotics for that patient. Okay? So if you know someone on multiple antipsychotics, first of all, if you're on antipsychotic, I mean it doesn't work. You got the wrong antipsychotics. If you're on multiple medication for the same thing, that means the drug doesn't work. You're on the wrong drug. Okay? So you have to find out which drug works for you and stick with it, or slowly get off if you're getting better. Okay? But physicians don't learn this way. Physicians learn if you have a condition, there's a medication. So now, you go to my class, you think it differently now, right? When you walk out here, you think it twice when you take a medication. Yes?
do physicians respond to your recommendations?
Legally, they have to.
Okay.
If they deny my recommendation, they have to document why they denied it. Because surveyor will come in, usually they will find a facility, they will tag them, and then the facility have to pay fine because physician don't read my recommendation or response to it. So that's a legal document. So if a patient died, I have a patient in May, I have a surveyor call me up and say, this patient died, I need to see all of your recommendation. They do go back and check pharmacist's recommendation. It's a serious stuff, and some physicians ignore it. I was like, it's patient's death. You have to, like, they pay you to come into the facility. You have to do the work that you're supposed to do. Yeah, so, yes.
I can say that I had Dr. Tran do an evaluation for my husband, and she puts it in such a way in the report that the doctors were not, what's the word, offended or threatened by the way, and she said, I suggested unconcerning asbestos. Yes, and I would suggest, baby aspirin, perhaps, and she does it in such a way, everyone, his primary care and 2 specialists, all agree. I can deal with that. Yeah, I would go along with that.
So the physician just need to get an ID to work with pharmacists. They afraid pharmacists step into their comfort zone and take over.
Mm-hmm.
We don't take over their stuff. We don't want their stuff. We just want to help the patient, that's all. So now Medicare make pharmacists get more into helping the patient, because we the only one who can speak up for the patient. Sometimes the nurse will. The nurse say, I don't like that patient on so many meds. Can you help me get them off? I have some nurse saying that to me and say, okay, but they cannot take them off themselves. They have to have a pharmacist write the recommendation. So, and then you can do the same thing. You can ask your pharmacist about that. You write up the recommendation you want to, and then you say, this is what, say, per Medicare. And now Medicare will tag the physician if they prescribe opioids. So Medicare will get on physician eventually for overprescribe antipsychotics and opioid to elderly patient. So it will come to
I have a question about that. So patients go to have a whole bunch of different doctors, and they're on a lot of mixtures they probably shouldn't be on. So does Medicare catch that?
They will eventually.
Eventually, okay.
Yeah, and then the way they catch it, it's not right away. It's like 2 years after. And they will reduce the reimbursement rate. So if a physician is smart enough, go ahead and work with a pharmacist, and then smooth out the medication list before Medicare catch on, because they have all the claims. Right? If you fill a prescription at pharmacy under that physician, it's all go to Medicare or insurance company. But they don't do anything until 2 years after. They're 2 years behind. So a lot of physicians drop out Medicare because of reimbursement rates, right? They like, I don't like to take Medicare. Medicare don't pay. Actually, Medicare pay more than regular insurance, but because you don't know how to treat your patient. So if the physician know how to treat the patient, like keep them healthy, keep them out of emergency room in the hospital, their reimbursement rate will go up. So 2 years from now, one physician will get 7% fine, right, reduced, but another physician will get 7% bonus, and they keep going up, bonus, like 9%. It will keep going up if that physician treat that patient very well. So the bonus will have more than the regular insurance. So physicians don't know that. They say, well, Medicare don't pay me much. Why? Because you don't spend more than 5 minutes with that patient. You don't really care about that patient. So that's why their reimbursement rate goes down.
So that brings me to another question. We have all these Medicare Advantage programs where the Medicare is not in charge. The insurance is United Healthcare or wherever is in charge. So what happens in those cases?
They will follow Medicare. So if they will evaluate the physician. how many of your how many patient of yours get into emergency all the time because of side effects of medication? Or how many therapy you help the patient to get off of antipsychotics, any documentation? They look into all the claims. They say you are not a good doctor. So next year, 2 years from now, you will get 7 or 9% less. So instead I reimbursed you $10, I reimburse you less than $10 compared to another physician down the street. I reimburse them $20 because they did a good job saving Medicare millions of dollars compared to you, your patient always in hospital. Make sense? And or your patient always get out of hospital and come back within 30 days. You get money on that because you don't follow up. So that's why some physician, very smart, they hire pharmacists looking at them, make sure it's everything clean for them. So 2 years from now, they get bonus, they get pay raise for Medicare. They make more money than regular insurance. I can tell you that. A lot of physicians in the East Coast doing that, and I don't see it in Oklahoma yet. I hope someday somebody will. Okay, let's go on to side effects of antipsychotic or psychotropic medication. So there's a reason why Medicare concerned about psychotropic medications. There's a reason why they make into law. Okay, so the new Oklahoma come up with new law last November that pharmacists have to look into psychotropic use of medication in assisted living. Usually assisted living get off the hook from Medicare or assisted living just like community.
No, they don't get evaluated. The state doesn't.
Not at all. So Oklahoma come up with a law that pharmacists have to look into antipsychotic use, just antipsychotics specifically, the monitoring antipsychotic use in assisted living. So that's an extra step that some of the nurses in assisted living didn't like my recommendation because they haven't monitored the patient for years. And now Oklahoma come up with that law that we have to monitor everybody on antipsychotics in assisted living. So eventually it will make primary care physician in the community doing the same thing, right? So slowly the law will change. But the point is to help patients to get off. That you only use it for short term, not long term, because there's side effects. And I just want to go down the side effects here. So you see a lot of side effects. No, you don't have to memorize any of this, but if you see some change when you start a medication, you see some new signs and symptoms pop up. First, you always think, what's the side effect? Is that the side effects of the new drugs I'm on, or I'm getting old? Okay, do not blame that you old, you get more, issues. No, sometimes it's because of side effects, because the drug cannot clear out your body fast enough. It builds up, you get toxicity, and then you have issues pop up. Okay, does it make sense? So the next 2 pages, this is just the side effects. So one thing they concern in the nursing home or in the community is fall. The first thing you always think about fall is what medication that called sedation or dizziness or headache. So I have seen many physicians treat falls, put them on vitamin D. I was like, that's not solving the issue. Not put you on calcium and vitamin D will help prevent falls. You have to get people off the medication or lower their dose. Then that will solve the issue. Not put everybody on vitamin D and calcium and count it as the way you treat falls. And I see that recommendation in nursing home, like, oh, patient have risk of fall, please put them on vitamin D. Say, well, that's good, but you have to look into the cause of the fall, okay? And also have some abnormal movement. So that's the law the new law, the Oklahoma new law, the assisted living and skilled nursing home have to monitor the abnormal movement. That's one of the side effects of antipsychotics. So guess what? People start getting on RT Parkinson disease medication. I was like, okay, you build up more meds. It just, you monitor abnormal movement, and then you see, is that time to get the patient off that antipsychotics, instead of say, hey, patient have Parkinson disease. So we have what we call is pseudo Parkinson. It's not really Parkinson. It's the movement caused by the side effects of the medication, not because they really have Parkinson. And
tardive dyskinesia.
tardy, or any kind of movement that you think, oh, she might have. And sometimes you see, I have seen some patients have tremors. My father-in-law have tremors, and it's just the side effects of lithium. So if you have somebody on lithium, sometimes that's have tremor. Guess what? He's on anti-Parkinson disease at the end of his life, and it's really sad. And I cannot speak up. I'm like, no, that's wrong. Just get him off lithium. And he doesn't. To me, I don't think he have bipolar issue. I don't. With antipsychotics, or people have psychosis, sometimes you have to look at closely. There's certain people that in both worlds, that mean like in real life, and sometimes they can see stuff that not real, but really that's just normal for them. And to us, because we can't see what they see, and we blame them have hallucination. Okay, so to me, it depends. You have to evaluate those people, because I have read many books that people have diagnosis of bipolar. They don't really have bipolar. They're very smart. They can see, they in the real world. At the same time, they can see other stuff that other people don't see. So same with Albert Einstein. He sees stuff that not that normal people like us don't see. So sometimes you have to reevaluate which one really psychosis, like going crazy, or which one is just they see stuff that we don't see yet. Okay, so
like a medium type
a
thing.
medium. Yeah, medium can talk to all the souls. So if you go to a medium, they see the same stuff. So we can tell them they have psychosis issue, but they are science proof. Right now they're doing research on those type. So the University of Arizona doing research about medium, or people that can see or talk to other entity that non-human. So we can have to be careful with that too.
What is people on lithium for? Why
Bipolar.
Bipolar or psychosis. It's one of the antipsychotics.
I see.
Okay, so go back to so if you read through those pages about adverse consequences, do you have any questions? So the main thing I wanted to talk to you is the abnormal movement, the side effects. That side effects that really concerns. That's why it put into law. Okay, so supposedly a physician have to monitor that, ask you about that, instead of put you on anti-Parkinson medication. And then guess what? You're gonna be on antipsychotics for Parkinson's disease. There's a drug for that too. So it just one drug leads to the other, but in fact it's just the side effects of the original drugs. Okay. So gradual dose reduction. So this is why I have a job. I come in and reduce the dose. So every quarter, so every 3 months, every 6 months, and annually, I make recommendation to reduce the dose. The doctor can deny it. They can accept it or deny it. Doesn't matter, as long as they have to document that they check with the patient still have the symptoms, so the patient need to be on that medication. So that's the appropriate way to do it. But like I say, I might see nurses, like psych nurse, get on the floor, check on the patient and document it, then that's fine. But I feel like I don't agree with certain physicians who don't see the patient and say, no, the patient still have to be on it. And guess what? Surveyors and Medicare don't like that. They want real documentation that you check on the patient and you agree with the pharmacist or disagree with the pharmacist. So this is the law. In nursing home, they have to reduce the dose for psychotropic medications. And we have to remind physicians all the time. So that they have to reduce that, and they have to use other interventions that help to improve the patient condition. Does that make sense? So now you know, even you not in the nursing home, but for you, if you take a psychotropic medications, it's time to ask physician to reduce the dose for you. I say, doc, can you reduce half of the dose for me and see how it goes? If it doesn't work, that's fine, you go back. It's not gonna hurt you, but you give yourself a chance to get off that medication. Does that make sense? So if you know your friends, your family member on a high dose psychotropic medication, just ask them, ask physicians, see if there's a chance to reduce the dose. Or if you see duplication of therapy. I see nursing home patient on 2 SSRIs. I don't understand why you're on Lexapro and Zoloft, the same class of drugs. And you get more side effects when you're on both a drug at the same time. I see patient on 2 PPI. And I make recommendation for 6 months. Nobody look at my recommendation. I'm like, what's the deal here? That means the doctor ignored my recommendation for 6 months and 2 patients on 2 PPI. Omeprazole and benzoprazole. And sometimes it happens when you transition from the hospital to nursing home or from the community to nursing home. So at home you take that medication, but in nursing home sometimes physician will change to their formulary or whatever reason, and that have duplication of therapy. So when pharmacists come in and check and say, hey, that's a duplication, you have to change it, discontinue, do something about it, or maybe get rid of it if the patient no longer have that condition. So now you understand it's really important when you transition. Now if you get into a hospital and go home, make sure you ask a pharmacist to look at your list, because sometimes when you get into a hospital, they don't have the expensive drugs that you have, so they have to substitute with something, and then when they discharge you, they renew that, and guess what? And then you go back home, you take your medication and the medication from the hospital, and you think that's a new drug, and that's caused the issue, and then you fall, and then you have side effects, go back to nursing home, because nobody now gonna take care of you at home anymore. So be careful when you get admitted to hospital. Only have somebody look at your list of medication. Make sure there's no duplication of therapy, and there's no drugs that not appropriate for elderly. Okay? Because we have a list called the Beers list. Dr. Mark Beers come up with a list of drugs that not appropriate for older adults. So you have a list. For example, Benadryl. Benadryl is not appropriate for older adults because it may cause psychosis. Okay?
Really?
Yes.
Wow.
In older adults, it might
What
cause
do you
psychosis.
consider older?
65 and up. That's his list. 65 and up.
Really?
So if I see Benadryl on patient list, I have to make a recommendation to discontinue it. Because if I don't, Medicare will come back and say, that's on the bill list. Why is it on this medication list? Because all the claims that you submit to insurance go through Medicare. Medicare will go back and say, why, doctor, why you put the patient on the bill list? It may cause fall. Guess what? They end up in the hospital. It's your fault. It's the doctor's fault not to discontinue that Benadryl or cause psychosis. Guess what? I have seen patients on Benadryl, and a few days later they on antipsychotics. I see that. So, and I told the nurse, get them off Benadryl, then get rid of antipsychotics. The reason they on bust out, go crazy, because of that Benadryl that dehydrate that patient. Yes.
Alternatives to Benadryl?
You can try Claritin. Claritin is 2nd generation. Benadryl is the 1st generation of.
Just a broad spectrum
Benadryl is a wonderful drug. Wonderful. You only use as needed. You don't use every day. So yes.
Spell Beers. Is it B-E?
Beer. Dr. Beers.
Yes.
B-E, just like Beers with an S at the end.
Oh, okay.
Yeah, Dr. Mark Beers. So
You can get the list, you can Google it.
Google it. The beer list. We call the beer list. Yeah. Yes.
Should we look for foods before taking any medicine? In other words, should we look for grapefruit rather than taking Atavastin? So the doctor prescribes Atavastin. The doctor did not prescribe grapefruit. But should I say, I'm going to hold off for 6 months and do the grapefruit thing?
Gotta be careful with grapefruit.
Yeah. Nobody in blood pressure can take grapefruit, right?
Grapefruit, yeah, the reason because it's they use the same enzyme system. So you just have to be careful when you on medication, if medication is more important for you, then you have to avoid grapefruit. That's just for your safety. And if you choose the other round, then you do it without taking the medication.
Right.
So that's part you have to discuss with pharmacists and see which medication that will interact.
My point is that the physician can control the amount of the pill.
Yeah.
The physician can't control, but your body will control how much you absorb.
Right.
So, but they know zero about nutrition in general.
Mm-hmm.
So we should push back first and say, give me 6 months and then I'll take it. Yeah.
Please do that. I love that. I don't like a pill for an ill. I don't like a quick fix. It takes time. If it takes 30 years for you to have that disease, it may take 30 years for you to heal, or it can be faster. So you have to give your body a chance to do it, okay? So I love that. You have to try supplements, vitamins, food, all of that first before you get on to medication. And once you get on, get a low dose. Don't jump into the high dose, okay? Okay, so we're done with dose reduction. Any questions so far? Are we good? Or are you lost? I want to inspire you. When you get home, you help someone, even though one person. You can help that person get off one medication.
Well, I recommend a lot of my clients, and they're at home, but I see the medications they're on. You need to go talk to your pharmacist and have them review because they get them from different doctors.
Mm-hmm. You have to get a geriatric pharmacist.
You have to get a what?
A geriatric pharmacist. A pharmacist that specializes in elderly patients.
Boy, what do you
Big difference.
That's her.
We don't have many geriatric pharmacists here in Oklahoma. Big difference because we train differently. We look at medication differently than regular pharmacists. So the new pharmacists, if they just get out of school, they just have the same mindset like physician, and a pill for every ill. If you constipate, you better have constipation medication on board. I'm like, no, you tell patients to eat more fiber. Mm-hmm. So I look at stuff differently. So
it's just like the pediatric has specialty. I mean,
pediatric, cardiology, pharmacists have the same thing like physician. Any specialty physician have, there's a pharmacist that go along with that specialty. So we train differently. So if you put me as in pediatric, I don't know about kids stuff, so I can't make any advice so specialized in kids. But if you ask me anything about senior populations, elderly, I can tell you what should be on, what should not be on. It's different. We are different. I don't know why physician thinks that elderly patient is the same with younger adults. They're not the same. Mm-hmm. Just like the kids are not older. The kids is not adults.
Okay, we're obviously not in the nursing home yet.
You don't want to.
So right, and we don't want to, but a lot of us have health conditions.
Mm-hmm.
Go to multiple doctors for different things. Try to have one pharmacy for the most part. Mm-hmm. But they're busy and you can ask questions, and they're polite for the most part. So if we want to ask questions and things, do you or other peers of yours have a situation where we can call and say, I would like to bring all my medications and have a 30-minute consultation.
Yeah, you can do that. Yeah,
Okay.
or you can email me. Sometimes, right now, I used to do that as my side business, but now I do full-time in consulting. So I don't, you just email me your questions and email me your lab, then I can tell you, I can write out
your lab?
your lab. I need to see your lab before I make any changes in your meds. I need to see your kidney and your liver. How's that doing first?
Yeah.
And then I specifically target the drugs that affect your kidney, because you have to start to protect your kidney and your liver first before you make other changes. So I usually target those first. So you can email me your list or ask your friend. So I just help out. I don't, not really, I move out my office, Alvani, you know. So I help you. So just email me if you have your list. Email me. I make a recommendation report. You can bring it to doctor. I give you warning. They may trash it, okay? Because they feel like pharmacists step on their, you know, things. So, territory.
Can you give us your email address?
It's just work with Trang at Gmail. Trang, T-R-A-N-G. So work, W-O-R-K, with W-I-T-H, Trang, T-R-A-N-G, at Gmail.
Thank
so
you.
I want the list, I want the lab. If you miss the lab, I can't make any changes on your recommendation. Yeah.
Typically, the doctor will run whatever labs he's looking for, and so he'll miss whatever he's not looking for.
Then I will recommend you to check on that.
Do you want to recommend a standard list? Okay,
Yeah.
I'm going in August. What lab should I request?
So, so you have CBC, CMP, right? So I want your B12, your folate, your vitamin D, your thyroid. Those are typical nursing home. And if you take magnesium, I want to see your magnesium. If you take iron, I need to see your iron. So whatever supplement you take, I need to see that lab, because sometimes you overdose it and it's not good for you. You want to be just normal. So I have seen people overdose in B12. You don't want to overdose in anything. So any vitamins that you take, you want lab panel for that.
Would the body not adjust for that and just discharge whatever you didn't need?
You do, but to the point, because your kidney and your liver, if you overwork that, you don't want to overwork that. It can at a certain moment, but if you do it years after years, then it's gonna burn out your liver and your kidney, and you don't want that.
Will you say that one more time, what she should ask for when she goes?
Okay, so vitamin D, B12, so if you take B12, you do B12. If you take magnesium, I want magnesium on everyone, because magnesium, if you low magnesium, you have insomnia, you have cramps, you have a lot of insulin issue. You have so many issues with magnesium. If you, back to potassium, if you cannot control potassium, sometimes it's because of magnesium. You miss magnesium, and a lot of doctors don't put that on the standard lab. So magnesium is very important.
Well, so like I was in the hospital a couple months ago, and they had to give me a shot of potassium.
So you low in potassium?
I mean, my doctor hadn't said so, but when I was in the hospital.
Maybe they check lab, and if it's low, they give you a shot, not infusion.
IV.
IV.
I don't think, I think they gave me a shot. Because it really burns and stings.
What's the limit on magnesium? If I take a magnesium pill and I take a multivitamin.
So that's why I say I want to see your lab. So you can take, like for heart failure patient, they should be on very high dose of magnesium. They should be like 1,000 twice a day. But for normal people who don't have a heart, what patient, so that's why I say depends when your body needs it or not. So like CoQ10 for normal patient with heart failure, you only take 100 milligram a day. For heart failure, you take 300 milligram twice a day. So depends on your condition and what you need. That's why I want to see your lab. So like, hey, with your condition and you on that medication, you might need to take more of that or take less of that. That depends.
Can you mention to them the kind of magnesium that you recommend, the slow mag?
The slow mag or magnesium aspartate. Slow mag is magnesium chloride, or you can, if you, a note here, if you have kidney issues, your doctor might not like that, you can try to soak magnesium, Epsom salt. Epsom salt is magnesium sulfate. After you soak magnesium sulfate, don't throw it away. That water is really good for your plants. So water your plant, it's a good fertilizer. So don't throw that. I always tell my mom, don't throw away magnesium sulfate. Put it out there to the garden. The plants will love it.
You said slow mag, and what was the other?
Magnesium aspartate.
Okay.
Aspartate.
Is that different than slow mag?
It's different. The one I talked last time here, anybody here remember I talked about the chronic fatigue syndrome?
Yes.
Aspartate, that the form magnesium aspartate is good for fatigue, give you energy. That's amino acid part. So aspartate is if you have chronic fatigue syndrome, you love magnesium, take magnesium aspartate. Okay? So there's a lot of magnesium out there. So pick the one that be helpful the most. And I want you to check your level. If it's low, then take a higher dose until it's normal. Any questions? Are we good? We're lost?
No,
Are we good? Good. Okay.
You're great.
Okay. Last page. Eliminate unnecessary use. So this is why I'm talking about the physician have to re-evaluate the patient every 3 months, 6 months, and every year. You see how many doctors doing that, or they just keep renewing your prescription. So, and so they have to monitor behavior and indication of distress. They have to try the non-drugs approach, right? And then they have to watch out for chemical restraints and wrong diagnosis. So this happened a lot, unfortunately, the wrong diagnosis. So like I say, the side effects issue. So if patient on Lasix, you put them on antipsychotic, Benadryl. Side effects of Benadryl. And now next day they're on antipsychotics. That's a wrong diagnosis to me. It's completely wrong. It's a side effect of the Benadryl. So that's very unfortunate. If the physician don't learn about medication and side effects, then they don't recognize that. Or if they don't specialize in geriatrics, they don't recognize that. So a lot of long-term care physicians, they claim they are long-term care physician, but I don't see many geriatricians here in Oklahoma. I talked to the Department of Geriatrics. They say a lot of physicians don't like to specialize in geriatrics. They don't have a very low residency rate, so they don't have. So we don't have a lot of geriatricians here in Oklahoma. I know Dr. Ross is a good one, Karen Ross, but she didn't accept any more patients. Some doctor at OU, a geriatrician. So if you really want to see a real doctor for your age, go to OU Department of Geriatrics. They have geriatrician. They have real geriatrician, and they have pharmacists that working with them. I think Dr. What's her name? Dr. Lee. I think so. She's the head of the geriatric department. But anyway, if you want to see a real geriatric physicians, they'll talk to you differently. I guarantee you, compared to your primary care, they talk to you differently. They look at your medication differently, okay? And they will recommend stuff differently too. So if you want to give that a try, second opinion, go to geriatric department, OU geriatric department, okay? So you don't have to see geriatric pharmacist. At that point, if you see a physician that understands what you're taking, what side effects, what need to get off, then that's good enough, okay? Okay, on the last part, what helped you to sleep? Back to your questions, melatonin. Did you see melatonin is bad for kids now? They overdose, melatonin overdose. Isn't sad? It's just a supplement. See? Now you learn supplement can be bad for you if you way overdose or depends on it. It's bad for you.
They started selling melatonin gummies for children, that's why.
So melatonin, the best melatonin is the melatonin that's produced by you at night. In order for your brain to produce melatonin, you have to have no light in the room. If you have a tiny bit of light in your room, your brain will not produce melatonin. So it will convert serotonin to melatonin. So serotonin, when the morning you open the window with light coming in, your brain will produce melatonin, serotonin. And at night, when everything's shut down, your brain will convert serotonin to melatonin. And when you're in deep sleep, melatonin will convert to another supplement, another chemicals, I forgot the names, but it's like antioxidants that make you live.
Yes, I have clients, I'm a therapist, that, I mean, they keep their apartments so dark, and they have low energy, so it's.
So in the morning, you have to open the window.
You have to have that light. I can't, but they don't.
In the morning, you have to you need sunlight to make serotonin. That's why people depressed. Like I heard people in Seattle got depressed because they don't see a lot of sun. Because you need that sunlight to make serotonin. So you can take medication as much as you want to, but your brain does not produce that.
It's called Hawthorne effect. It was studied by Bell Labs back in the 30s.
Okay.
And they learned that bright lights in manufacturing facilities made you happy, made you want to work more. I mean, it's all about serotonin.
During the day though, but at night it just makes you tired because the body, it's just a cycle, right?
Well, it depends on the shift you're on. You want it bright at night if you're working third shift.
Yeah, so I used to work at the VA and we have to rotate through overnight. I hate it because I have to work I have to sleep in the closet for months.
Been there.
Because that's the only place that have no light during the day. So I hate it because now your body messed up, the cycle messed up. But yeah.
You mean as much light in your room as a phone plugged in? That will also deter, right?
Yeah, so you don't want an electronic device in your room.
Wow. Like
Okay,
your
the
clock.
light.
Your red clock, though, with the red letters, that's not an issue.
It can trigger too.
Really?
Yeah. So it have to you don't see any light, period, because you don't know how your brain going to react. If you see light, that means hey, time to wake up. So that's the best melatonin. So before, and then I heard I follow a psychiatrist. I took a class in brain health with a psychiatrist, and he recommend before you go to bed, eat a piece of toast. Toast, bread, because bread will make you happy. Okay. Somehow that will help to produce, help convert to serotonin, and then when you sleep, it converts to melatonin. Somehow that piece of toast that will make you happy and sleep well, instead of that's how you make help to make natural melatonin.
That with butter and jelly too?
Don't overdose it. But that's
That
why
make you too happy.
he say that's why when you go to the restaurant, they give you bread before the dinner. Why is that? They do it for a purpose. They serve you bread. They do it on purpose. They make you happy. They make you happy. Then he said that just
Doesn't it make you happy when you get the bread and
a piece of bread make you happy.
And olive
I
oil.
never thought that.
Yeah. So they do it on purpose. It's not that he said it's not coincidence. They serve bread at the beginning, and then make you order more, right? Okay. So now you know. So he say that's to a piece of. So I usually eat sweet soup. So I eat. I don't eat bread, but I like to eat something sweet, like some beans, like sweet beans. But okay, American culture eat beans in salty way. We eat beans in a sweet way as a dessert. So I like to eat beans. The beans have carbs and stuff.
From where? Where are you from?
Vietnam. So we eat beans in the dessert way. So if you go to supermarket, we don't eat beans in the salty way. So, okay, so back to the last part. So I'm doing a fellowship now in integrated medicine. I will graduate next year. So most of my presentation, I will tell you other integrative way to help improve your condition so you can get off the medication. So on the last slide, it will tell you all the techniques that I have tried. I've tried myself, and I can tell you it works. Okay, you have to give them a try. The first thing, when I saw my therapist, so I have a brain scan. I scanned my brain. I have PTSD. I didn't know. I thought I have ADHD. See, you can get the wrong diagnosis if you don't scan your brain. You have to scan your brain. Like even dementia, there's like 7 or 10 types of dementia.
So how do you get your brain scanned?
I go down to a clinic in Dallas, and then I scan my brain. So it showed that I thought I have ADHD, and it's come out I have PTSD. So I went and see a therapist. The first thing she told me to do is to relax and do the breathing. So like just put my hand on my chest and breathe. So just do 4 in, 4 out, 4 in, 4 out. That's the first thing my therapist teach me to do is to relax. So, and from that time, I learned so many techniques that can help. I have done hypnosis. Hypnosis is really good for sleep also. So you can turn on your YouTube, just type in hypnosis. There's so many programs on YouTube can help, or you can buy CD or DVD if you want to. And doing that, hypnosis is really good. Heart rate variability, that's the one I tell you. Just put your hand on your chest and breathe. Just 4 in, 4 out, 4 in, 5 out, 4 seconds in, 4 seconds out, and you just say, you can say, hey, I'm still alive, I'm still breathing. You just appreciate, oh, thank you, the Lord. Whatever you want to do, just put your hand on your chest. And your heart have a, what it called thymus, a glands here that produce the T cell immune system. The T cell that you heard on during COVID, T cell, B cell. So B cell from the bone, T cell from thymus. That's one of the very important for the immune system. So if you touch your, or knock on it, knock on your heart, or touch it, that help to activate more T cell for you. That's to boost up your immune system. So you can tap on it, touch it, do something with your heart every day. I can tell you, it will help to, you don't need to take other immune supplements. You just need to activate what you have in your body. So you activate by touching your heart every day. You activate that thymus gland that produces the T cell, okay? Guided imagery, this one is also for relaxation. If you go to a therapist that know how to do this, they can help you. It's similar to hypnosis, but not put you to sleep. Journaling, I learned so much from this one, especially male patients. They don't want to talk out their problems. So usually with male patients, I will recommend journal. So they need to write out deep inside of them what's really bothering them. So they have done research for patients have issues with IBS, with diabetes. I think they do some research in different disease, and they just ask the patient to journal out, especially male patient. Journal out their deepest concern, grief, whatever happened when they was little, the trauma, they have to write it down. When they write it out, they can burn it. They don't have to show it to anyone. But if they don't talk it out, any trauma, they need to bring it up. If they don't bring it up, it's still in their body, and they not will heal completely. So they do research about this, and when I take the men's health class, I read a lot of chapters in my integrated medicine books, and they recommend journal. So if you don't like to see therapists, journal. Just like you cry it out. Say, women, we cry. We talk it out, we vent it out, it's gone, right? But if you keep it inside of you, you're gonna have heart failure or blood pressure issue. And then forgiveness and meditation. So forgiveness, just back to trauma. So trauma, any abuse issue when you grow up, if you keep bringing with you, you only live in the past. So your body don't have a chance to heal if you keep living in the past. So forgiveness and move on. That's very easy to say. Very easy to say. But once you do journal, you will understand more, like your life purpose. What's the meaning of that event happened to you? There's always a purpose for that event, why it's happened to you. So when you write down, you will discover, it happened because of that. So, and then you don't take it seriously anymore. So it's very easy to say. Like I say, you have to practice. And one time I journal, I just cried out. Like, I feel like, oh, it happened because I'm thinking this way. Sometimes we have the wrong, we think the reason for that event happened. Sometimes it's not really the real reason for it. But we think it that way, and we think it's bad for us or whatever. People want to harm us. So sometimes if you journal, you will find out that there's always a reason for things happen in your life, some for better, for worse, and then you need to move on if you want to live healthy. But it's very hard. It's very hard. It requires a lot of practice. But when I practice myself, I feel like I cry out when I journal. You don't need to talk to anyone to cry out. You just write it down, and you feel so much better the day after. That's how I feel the day after. When you were bust out crying the day before, you feel better the next day, and then it keeps you move on. But you always start with what is your purpose in this life. It's more the spiritual questions, but really, what make you wake up every day? What make you want to live longer? What make you come here today to learn about this? What make you? So you have to think about that. Okay, back to the questions here. What medication for Lewy body dementia? So I can tell you dementia medication doesn't work. Yeah, all your Aricept, donepezil, all of that doesn't work. I can tell you that. It might help at the beginning, but at the end, it will not work. But it gives you more side effects. Here's the side effects of Aricept. So Aricept, usually doctor will, start with physician, the manufacturer recommend to take it at night. Aricept will make people go to the bathroom at night. And then you get, so now you have issue of incontinence. And then this is a cascade, prescribing cascade right here. Okay, you have dementia, you're on Aricept. You take Aricept, you go to the bathroom at night, and then the doctor will put on incontinence medication. When you take on incontinence medications, you get other issue. And then you just go back to, at the beginning, then dementia issue won't go away. The best supplement for dementia is do all the brain health supplements, plus you have to change your diet, okay? The diet is, if you think that diet is not good for your brain, you're gonna have dementia. So our brain is very wonderful. Don't ever give up with your brain, okay? It have what we call is neuroplasticity. So it's like plastic. It can regenerate and make new cells. So you always have to activate your brain. So going to class like this, activate your brain. You want to learn more. You learn something new today, you make new cells. So if you stop learning, that's why a lot of people, I feel like people when they retire, some of them commit suicide. Some of them just like die earlier, depression, yeah, or die earlier compared to the college that never retire. So learn something every day. Learn something new. Don't listen to the same stuff on the news every day. Okay? the news make you go crazy, so don't. Stay away from the news channel.
That's right.
Yeah.
I want you to, from now on, I'd rather you listen to something that make you grow. Okay, go to class like this, or many class that Marilyn has.
So playing games.
Playing games bad for you.
That's bad for them?
Because it's repetitive. You have to learn something that make you think and grow. Make you a better person. So if you practice Qigong or Tai Chi, a lot of movement, you have to think. It's not, it looks like repetitive, but I practice this, I like, no, you go this way, that way. You know, you have to figure it out. So do it on treadmill. I think treadmill is repetitive. Okay, walking on treadmill is repetitive. If have no use, it can help produce serotonin for you, make you happy. But walking down the street in the neighborhood is better for you than on the treadmill. Okay, that's a different kind of exercise. So you have to make better decision.
Well, I'm gonna go back to the dementia. How do you stimulate a dementia patient's brain if they don't do word search or?
You know, the best way to distinguish different dementia is to do brain scan, because there's different area of your brain. The psychiatrist that I learned from, he said that it's different form. The only way you can do it is to go to specialists that do the brain scan, do all kinds of testing, and then they'll find out which one is the correct one. But in general, you have to make your brain grow again. If you stop doing that, you have even worse symptoms of dementia. It doesn't matter what kind of dementia, because of your brain is, first of all, they lack of water and supplements. So
it's on Lasix. So.
Yeah, now you know. Okay, hair. Well, for hair, if you lose hair, there's a lot of reason for it. It can be the side effects of medication. Certain medication like amiodarone can do that. This medication might have the hair issues. It can be your shampoo. It can be the water, the tap water. Because in tap water, there's only lots of toxin in there. So make sure you go to Lowe's and buy a filter. There's a filter for your shower. Filter those, okay? And replace that filter. So go to Lowe's, buy the filter for your shower, okay? That will help. And then you can take hair supplements if you want to, but eat a lot of avocado. This is my trick. You see a lot of Hispanics, their hair is very thick. Did you look at them? The Hispanic population, I guess they eat a lot of avocado. Their hair is very thick. So when I get pregnant with my kids, I read in a magazine for kids that their mom want kids have lots of hair, it's lots of avocado. So put avocado daily in your food.
Put that on your toast before you go to bed.
Yeah, that'll make your hair, okay? So that's because in avocado, there's a lot of vitamins that are good for your hair in there, okay? But you can take supplements you want to. So you have to treat your water, okay? Your shampoo, make sure you buy shampoo that have the least ingredient in there. There's so many ingredients in shampoo. It makes it so complicated, okay? So you treat your environment. Look, with medication, you cannot get off your medication, right? So you have to go other way to help get more hair. Yes.
There's a popular supplement, the biotin.
Biotin, yeah, that's fine too.
My sister says when she takes it, she notices a really good difference. But if she stops taking it, then her hair starts coming out again.
That's fine.
It makes my nails grow.
Hair, nail, yeah. So if you cannot get off medication, then you have to find other ways to control it, okay? And massage your head every morning when you wake up. Massage it. It helps blood flow. It helps with your headache also. So you massage your body. Why nobody massage the head? Massage the head. Okay, cholesterol medication should not be. I'm sorry, I cannot read this long.
Is there some age determination when a geriatric person shouldn't?
You should get off cholesterol medication. Yes, good. Cholesterol medication, statin drugs. I would recommend after 70, if you're pretty healthy, the cholesterol normal. Again, if you're in my class several classes ago, I tell you what is the number for a normal cholesterol. If you normal, your cholesterol is normal, means your HDL, LDL, triglyceride in the normal range, get off, because that will cause dementia. Cholesterol, when you're young, it helps with inflammation, it helps blood flow, great, awesome. But as you get older, you have to get off, because it will make you have anemic. You become anemic when you're on cholesterol medication. So yes, I would recommend after 70, just like you have to get off aspirin, you have to get off cholesterol medication, but only if everything is normal for you. When you do a blood test, everything normal, I say, doc, it's time to get off, because it gives you pain issue. You have to be on pain medication because of your cholesterol medication. Now starting to have side effects on you. Instead of helping you, have more side effects. But I give you warning, doctor will not let you get off, because they want you on it because it looks good on their profile. Okay? I can tell you a lot of doctors put on because they put you on aspirin because it looks good on their profile that they're patient on aspirin, or they look good on their profile that now they're patient on certain meds. It's really sad, but they go through, when they in a hospital system, they have grades, they check off, hey, do you have your shot yet? This shot, that shot, or this med. So cholesterol, aspirin, on the list. So good luck.
Is there another thing to take besides the cholesterol meds they want you to take?
Yeah, there's a list of criteria. Depends on which hospital they work for. They have checkoff lists. I'm serious. Yeah. Do you have pneumonia shot yet? No? You better get it, because they're going to make you.
Oh, Mercy has.
Yeah. So if you have, I hate this one. If you have diabetes, but you don't have cholesterol, guess what? You have to take cholesterol medication. That's on the list. So,
so is that a yes or a no? Is there something else? Something else in place of the statin drugs that they like to shove on you?
To help lower our cholesterol.
To help lower cholesterol. Is there something natural?
No, they love statin drugs.
But can we do something to help lower
diet?
Diet.
Is that what you're asking?
Yeah, I mean, yeah, I know diet, but is there...
Statin is on the list because of the
So there's not a supplement or something good or for it?
Guideline? Somehow statin company, they make it into the guideline.
I'm taking a cholesterol pure plus. I have it right here and what's in it, and I have dropped my cholesterol 30 points.
Good.
And so I will know, because that was the first time I tested it and then went, and so if I can get off of it, because that was the deal, was we'll put you on a low statin, and it's like, no, we're going to try it. With that.
You can always stand up for yourself, right? And say, no, this is normal. I'm not going to take it until, if it's bad.
I was put on a statin and I suddenly was tired. I could not get myself down the stairs from where I was. And I told my doctor, he said, are you sure it was that? Yes, I am, because that's the only thing that I was given. Just can't take statins.
Right. So statin do more harm than helping you when you get older. So, but only if your cholesterol is good. If it's bad, be on it, But if it's good, normal, get off, okay? But I don't think the reason statin on the list of physician because of the guidelines, But the guidelines for younger adult, the guideline is not for older adults. That's the issue. That's the issue is a lot of guidelines doctor follow is for younger adults. When they do research on the meds, they don't get into nursing home and get patient on research, right? I wish they do, but they don't, right? They don't get a lot of elderly with medical conditions to be on any meds, research on meds. Okay, so dementia, cholesterol here. Any other questions? We have a few more minutes. Did you learn anything today?
Yes.
Yeah. So I hope you go home and help someone, help one person, or even help yourself, and that's great.